Welcome, and thank you for joining us. Today's presentation focuses on the economic impact of proposed federal legislation that would cap physician salaries and redirect funds to community health. We'll examine how this policy affects coastal medical centers' financial and clinical stability and explore strategic solutions, leveraging CMC's strengths to protect specialty care, access, and long-term sustainability. Next slide. This slide provides a snapshot of Coastal Medical Center, or CMC. CMC is a full-service licensed hospital known for its competitive edge in specialty care. However, it has faced significant financial challenges, including a $16 million net loss over the past year. Under financial concerns, we see that excessive labor costs, particularly physician salaries, are contributing heavily to this deficit. At the same time, reduced reimbursement rates and a decline in admissions and surgical volumes are further straining margins. These issues have also led to strained internal and external relationships, which may impact operational efficiency and patient satisfaction. Despite these challenges, there are promising growth opportunities. The region is experiencing strong projected population growth, particularly among younger, affluent residents. This demographic shift represents an opportunity for CMC to expand service lines, modernize care models, and better align its offerings with market demand. This context sets the stage for evaluating proposed policy changes, such as the physician salary cap, to determine whether they can address financial strain while supporting long-term growth. Next slide. To begin, let's look at the context of the current policy challenge facing Coastal Medical Center, or CMC. First, we're dealing with a legislative threat. A federal proposal aims to cap physician salaries at $250,000 and reallocate any excess into a community health fund. While well-intentioned, this policy raises serious concerns for hospitals like CMC that rely on high-earning specialists. However, CMC has a strategic advantage. Its Vice President of Government Affairs Department. This team is well positioned to engage in legislative advocacy and influence how this policy is shaped or potentially revised. The central problem is that this proposed law directly threatens CMC's specialty care services and financial sustainability. If implemented without adaptation, it could result in specialist shortages, decreased revenue from high margin services, and long-term organizational risk. Next slide.
This slide shows the utility trade-offs between providers and patients under the proposed policy. From the supply side, salary caps may lower physician morale and job satisfaction. And as a result of this decreased morale and job satisfaction, it can worsen workplace shortages and reduce care quality. Also, it raises reimbursement concerns due to the quality of care. From the demand side, reallocated funds may increase access to care, which is the intent behind this proposed bill, and promotes health equity. In addition, supports the social contract by providing services for the underserved groups in the community. However, improved access could drive higher demand, further straining the healthcare system. Overall, two key takeaways include: one, there's tension between provider utility and patient utility, and two, policy must balance labor sustainability with equitable access to maximize overall system utility. Next slide. The research we found highlights key points affecting healthcare supply and demand. First, on the supply side, growing physician shortages and maldistribution pose long-term access challenges. Lessons learned from the UK's National Health Service, including reduced medical school tuition, grants, and higher pay for specialty physicians, offer useful insights on overcoming similar barriers. In addition, demand is rising due to population changes and is further influenced by price elasticity. When care becomes more affordable, utilization increases. However, to address this, the National Healthcare Service utilizes primary care providers as gatekeepers and reinforces the importance of public health for patients so that they can take control of their own health. From a utility perspective, the literature reinforces the importance of social determinants of health. and how physician utility is often influenced by salary and work-life balance that physicians desire. In a value-based care environment, APPs emerge as a cost-effective solution to maintain quality and access, while at the same time optimizing revenue. However, due to the limited scope of these APPs, physicians are still required for oversight, and APPs are found to be the most effective in primary care settings. And lastly, healthcare lobbying plays a pivotal role in shaping policy. Both in the US and UK, cases show how targeted advocacy for reimbursement, workforce supply, and adequate pay can drive systematic change in the healthcare system. Next slide. In order to evaluate the strategic position of CMC in response to the proposed legislation, we conducted a SWOT analysis that looks at internal strengths and weaknesses, as well as opportunities and threats. Looking at its strengths, CMC benefits from a strong VPGA department and a growing and affluent patient base. And as a full service hospital, it's well positioned to scale and adapt. His weaknesses include a specialist dissatisfaction, a 16 million net loss, and declining volumes that highlight the need for cost-effective, high impact strategies. Opportunities include labor substitution with APPs and investments in social determinants of health can improve efficiency and equity. And lastly, threats include specialist shortages, policy instability, and APP over-reliance could compromise care and quality and financial sustainability.
In order to make sure that the interventions and policies that we are going to be providing, we'll be doing a couple of different analyses. One being a cost utility analysis, which will be used to study our investments into social determinants of health, or if the government chooses to fund those programs, as well as changes lobbying for physician salary. We'll also be using a cost-benefit analysis, which will allow us to look more at a financial lens of these policies for labor substitution, substituting physicians with APPs, as well as our physician salary approach. The rationale behind both of these measures is being able to, or both of these analyses, is to be able to evaluate both the quality adjusted life years as well as the monetary benefits of these solutions, as that will be critical to making sure CMC has a sustainable financial future. And then we'll be using a couple of parameters to analyze these solutions. One being the quality adjusted life years to assess improvements in health and the longevity for the community, as well as net profit and net cost savings, depending on which will be utilized in different approaches to determine the financial viability and sustainability of each solution. Next slide, please. So we used a cost utility analysis to determine if investments into the social determinants of health would improve quality adjusted life years across the board. For example, this could be investments into food and housing and security programs. And so we have several costs that would be dragging down, impacting this incremental cost utility ratio, and that would be the cost of lobbying, the cost of the salary reallocations, as well as the strain on the workforce due to these changes if physician satisfaction declines and they choose to leave CMC. Improving this or benefiting these investments into social determinants of health, we'll see gains in quality improvement life years, specifically around improved life expectancy and quality of life, of course. We'll also see reduced hospital readmission rates as we are addressing core root issues, especially if there are investments into food and housing insecurity programs. We'll also see improved access to care, especially for those who are underserved in our community. Overall, while there are upfront costs and operational risks, the long-term utility gains could make this a very cost-effective strategy, especially as it aligns with CMC's value-based care goals. However, because this is in control of the government controls how these programs are funded, we may see these interventions not sustain long-term and there could be variable shifts in how these funds are used. If the incremental cost utility ratio happens to be less than the government or CMC's willingness to pay, these interventions would be considered not cost effective. And then finally, we're looking at the cost, or another solution would be economic analysis that we performed, is looking at the cost benefit analysis of substituting physician labor for advanced practice providers. This would provide a lot of benefits around lower labor costs, as APPs have lower salaries, which could result in savings over time. This would also improve our access to care, as APPs can help address the overall provider shortages, especially in primary care and underserved areas. This also strengthens our workforce, as it helps strengthen care teams and alleviate physician burnout by integrating APPs into our care. There are some costs associated with this labor substitution, such as most APPs will require all APPs require additional supervision, which will add some indirect labor costs and limits our scalability, as we'll still be reliant on physicians. There are some limitations in specialty services. APPs may not be able to replace all the services that physicians are able to provide, especially in surgical or high acuity areas. And there is potential revenue impacts, where substituting physicians with APPs may affect billing and reimbursement rates. In terms of looking at this as a calculation on whether or not this will be a cost benefit, we're going to be looking at our cost labor savings, where we'll be taking our physician labor costs, which represents the current amount of dollars being spent on physician positions that we might consider replacing for APPs. And taking out the fact that we will have to pay these APPs. So that's why we have this APP labor costs subtracting out from the physician labor costs. And we're also needing to take out the physician oversight costs, as we'll have to allocate additional dollars / non-billable time to make sure that our APPs get the required supervision that's needed from a regulatory and legal standpoint. So while APP substitution is cost effective in many cases, we'll have to be careful around the implementation in order to balance savings with the clinical complexity of our patients that we serve, or CMC's patients.
The SWOT analysis highlights the organizational, financial, and policy factors CMC must consider when evaluating the impact of lobbying to raise the physician salary cap. Strengths of the solution include CMC's VPGA department is strategically positioned to shape policy in the organization's favor, and raising the salary cap could help attract and retain specialists, leading to long-term savings by reducing turnover and lowering the overall recruitment costs. However, potential weaknesses are the risk of growing tension among medical staff and CMC administration if salary differences widen, and raising the cap may not solve the existing problem of uneven physician distribution, especially in underserved areas or specialties. Opportunities include a higher cap could help CMC protect revenue from key specialty services and boost provider morale and retention, particularly in high demand fields, strengthening workforce stability and strengthening the specialty service line. Lastly, potential threats of this solution are policy changes or reversals could create uncertainty and disrupt long-term planning, and budget constraints may make implementation difficult or force trade-offs in other areas of spending. To further understand the impact of the proposed solution, this cost-benefit analysis weighs the economic trade-offs of raising the salary cap for specialists making over $500,000. Economic benefits include retaining top specialists and attracting future talent, reducing costly turnover, and preserving revenue from high-margin specialty service lines. Additionally, driving a stable physician workforce would improve access to specialty care, driving revenue and supporting CMC's long-term sustainability. However, labor costs will increase compared to the proposed cap, creating short-term budget pressure, and there are also lobbying expenses tied to advocating for the higher salary cap through the VPGA department. In conclusion, the upfront costs are justified by the long-term benefits in workforce sustainability, service line preservation, and revenue protection, making this a high-value policy adjustment for CMC. To further explore the solution from a cost-utility analysis perspective, this analysis evaluates the trade-offs in utility associated with increasing the salary cap. Costs include the capital CMC will invest in lobbying through its VPGA department to advocate for the higher salary cap. Additionally, raising the cap to $350,000 will increase short-term labor costs compared to the proposed $250,000 salary limit. However, benefits include improved health outcomes and better access to specialty care. Retaining more physicians means patients experience fewer disruptions in care, which improves outcomes and leads to gains in quality-adjusted life years. Additionally, a higher salary cap helps stabilize the specialty workforce, ensuring patients can access the critical services they need. While costs are present upfront, the long-term utility gains measured in quality-adjusted life years and improved access to care make this solution the most beneficial for CMC because it supports both organizational, financial sustainability, and improved health outcomes.
CMC must adopt a cost-efficient, data-driven strategy to safeguard financial and clinical outcomes. Our recommendation is to use the VPGA department to advocate for a higher physician salary cap to mitigate negative impacts of the proposed legislation. This action helps stabilize the workforce by retaining specialists, protect access to high-revenue specialty services, support CMC's financial sustainability in the long term, and aligns economic strategy with patient care goals and organizational resilience. The benefits of this strategy are clear. It will help stabilize the workforce by protecting physician salaries, ensure that the hospital can retain top talent. It will also allow CMC to maintain access to specialty services, which is crucial for its competitiveness in the healthcare market. Ultimately, these strategies will contribute to CMC's long-term financial sustainability. Next slide.